In this lecture, we will discuss third degree or complete AV block, including its mechanism, EKG features, potential causes, and clinical significance. In third degree or complete AV block, P waves are never related to the QRS complexes. In other words, there is complete absence of AV nodal conduction such that no supraventricular impulses are conducted to the ventricles. This often leads to severe bradycardia with independent atrial and ventricular rates, that is AV dissociation. So if you look here, we pretty much have our atria here on the top, our ventricles here on the bottom, that are completely disconnected from each other. So this is a form of AV dissociation. Now sometimes P waves precede the QRS complexes with a reasonable PR interval, such that they appear to be related. However, careful evaluation of the rhythm would show that in fact they are not related at all. It is simply a coincidence that the P waves and the QRS complexes seem related in such cases. So if you look here, if you look down at the end here, there's our P wave, and this is our QRS complex. You may assume that this PR interval appears normal, okay? But in fact, if you continue to look through the rhythm, here's our atria. These are all our atrial rates, our P waves occurring through. Here's one that's occurring in our T wave. P wave, P wave, P wave, okay? And eventually it's this one that's falling and appears normal, but actually, in fact, it's not, okay? So make sure you're evaluating the whole rhythm. Now the P waves march through, as they so call to, the QRS complexes at their own rate, okay? So these P waves are pretty much marching through, as we're saying here, at their own rate and not even minding our QRS complexes, okay? And the QRS complexes also occur at regular intervals, but at a slower rate, okay? So notice our ventricular rate here on the top. We have our QRS complex, another one, okay? Here's another one, and then we had the one at the end. So notice that the QRS complexes are occurring less often than our P waves, and that's why we have our atrial or P wave rate that is greater than our QRS or ventricular rate, okay? So if you looked here and we were to find the rates of these two, so let's just try that here, okay? Now if we looked at our P waves, so here's one P wave, and there's the next one, okay? So there's about two of the big thick lines between it, so 300 over 2 is 150. So our atrial rate's about 150, and if we looked at our ventricular rate, it's about 1, 2, 3, 4, 5, 6. So between 5 and 6, so 300 over 5.5 is about 55 beats per minute, okay? So a lot slower. So atrial rate much faster, 150, and our ventricular rate slower. So again, notice that they're just marching out the P waves, marching through the QRS complexes at their own rate. You can think of complete AV block as the endpoint of second degree AV block Mobus type 1 and type 2. That is to say, complete AV block may occur either from a lesion just above or below the AV node, just as in Mobus type 1 or 2 respectively. Like Mobus type 1, it can occur from progressive fatigue of the AV nodal cells. For instance, this could be secondary to an increase in vagal tone in the acute phase of an inferior infarct, whereas like Mobus type 2, it can occur due to sudden and complete conduction failure through the His-Purkinje system. This may be seen in the setting of septal infarction in an acute anterior MI. Okay, remember Mobus type 1, we had that lengthening, the progressive lengthening of our PR interval, and then the drop beat. Where in Mobus type 2, we had those intermittent, sudden dropped beats, okay, with constant normal PR intervals. All right, so let's look at both of these lesions. If the lesion occurs above the AV node, that is at the crest of the AV node, a junctional escape rhythm will take over and drive the ventricles. Therefore, in this case, we would see narrow QRS complexes at the intrinsic rate of the AV node, which is often between 40 and 60 beats per minute. Okay, so if you look here, let's just erase some of this stuff so everything's clear. All right, so now we're looking at two different lesions, okay? So we said one could be similar to Mobus type 1, the one that occurred above our AV nodes. Remember, this is our sinus node. This would be our AV node, okay? Then we have our His-Purkinje system, and then we have the split between the right and left bundle branches, and then the left anterior fascicle and left posterior fascicle, okay? Now the first lesion is this one here, okay? Right at the crest of the AV node, and this one's right there, and because because it's so high in occurring there where Mobitz type 1 would often occur, we can have a junctional escape rhythm, okay? Meaning that the rhythm can come somewhere within our AV node or AV junction or the His bundle area, and because of that we can get these junctional escape rhythm where we have narrow QRS complexes with a rate between 40 and 60 beats per minute. And if you recall, our rate here with the ventricles, remember we said was about 55 beats per minute. Okay, and notice that we also have narrow QRS complexes. So in this case, we likely have a lesion above the AV node at the crest. Okay, so maybe this person had maybe Lyme disease, developed Mobitz type 1 block, and eventually was not treated and progressed to this. Okay, and we have a junctional escape rhythm in that case. Okay, so that's that one. Now the block at the crest of the AV node tends to be much more benign and is usually preceded by second degree AV block Mobitz type 1, as we said. All right, remember that affects that area as well. Now on the other hand, if the lesion was below the AV node, the ventricles would need to be driven from an intrinsic ventricular pacemaker because no supraventricular impulse could make it through to the ventricles. This is more similar to a progression of Mobitz type 2. In such cases, QRS complexes are wide and the ventricular rate is the intrinsic rate of the ventricular pacemaker, which is less than 40 beats per minute. Oftentimes it'll be between 20 and 40 beats per minute. Okay, so now we're looking at that second lesion. Okay, and the second lesion is below our AV node. So we had the first one here, the second one at this point. There's our AV node. So this is occurring below it. All right, imagine it taking out both of our bundle branches, the right and left bundle branch, okay? And because of that, nothing from the top, no junctional rhythm can make it through. If we had one here, it couldn't get through that block. So instead, you have to have a ventricular pacemaker somewhere below this lesion, depolarizing and taking over the ventricular activity, okay? And remember, the intrinsic rate of the ventricles will be less than 40 beats per minute, okay? So obviously, this rate was at 55 beats per minute. Okay, so this wouldn't be a ventricular pacemaker, and this wouldn't be that case. And also, we have narrow complexes here. If we had a ventricular pacemaker taking over and the block so low, we would instead see wide QRS complexes because of that slow cell-to-cell depolarization. Now, a block below the AV node is often the result of ischemic heart disease, such as from an extensive anteroseptal MI or from chronic degenerative disease of the conduction system. It requires pacemaker placement as it can be life-threatening, and this is because the ventricular escape rhythm in such cases often has an inadequate rate, and there is the risk of ventricular tachycardia and asystole. Okay, so even though you may have a ventricular escape rhythm that comes below the block, it may be inadequate and really be life-threatening. Okay. Now, some causes of third-degree heart block include inferior and anterior MI, idiopathic degeneration of the conduction system, maybe from fibrosis, Lyme disease, medications such as beta blockers, calcium channel blockers, digoxin, amiodarone, hyperkalemia, as well as other causes that are responsible for Mobitz type 1 and type 2. Remember, this is pretty much the endpoint of second-degree AV block Mobitz type 1 and type 2. So anything that's progressed, if Lyme disease wasn't treated, it could progress to this, and you may have this as a consequence. Now, clinically speaking, these patients are at high risk for ventricular standstill, ventricular tachycardia, and sudden cardiac death. Therefore, they require cardiac monitoring and placement of a pacemaker. Okay, there's one last thing I want to mention before we go through our chart. Did you notice the relationship of the P waves and QRS complexes as we went through each AV block? In first degree AV block, we saw the P waves are always related to the QRS complexes. In second degree AV block, Mobitz type 1 and type 2, we saw that the P waves are sometimes related to the QRS complexes. And now in third degree AV block or complete AV block, we're seeing that the P waves are never related to the QRS complexes. Therefore, whenever you're trying to determine the degree of AV block, you should always examine the relationship between the P waves and the QRS complexes. Okay, so just so you're aware, P waves to QRS complexes. Okay, notice that relationship in first, second, and third. So this is the degree of AV block, imagine that. And then in first degree AV block, they are always related. So the relationship of the P waves are always related to the QRS complexes. In second degree AV block, okay, Mobitz type 1 and 2, they are sometimes related, okay? And then here in third degree AV block or complete AV block, we're seeing that they are never related. Okay, so I want you to go back through these, go through all the blocks, and notice that they're always related in first degree, sometimes in second degree, Mobus type 1 and 2, and never, as we see here, related to each other in this complete heart block. All right, let's briefly go through our chart before we end here. So again, complete absence of the AV nodal conduction, right, in third degree heart block. There's no supraventricular impulses that can get conducted through the ventricles, okay? So even though we may have an impulse coming from our sinus node, it just cannot make it through to the ventricles, okay? So there's no relationship between the P waves and QRS complexes, okay? We have AV dissociation. This is a form of it. And remember, the P waves pretty much march through at their own rate, okay? Here's a P wave. There's another. Notice that they're just going at its own rate. This one's within our T wave, okay? Here's a P wave, one at the end, P wave, and then the QRS complex going at the same rate as well. All right, still regular intervals for each of them, but they're just going at their own independent rate. Both, remember, third degree or complete heart block is the endpoint of second degree AV block Mobus type 1 and 2. Okay, we said if it's above the AV node, it's like Mobus type 1, where it goes and can progress to this form of block, or if it's below, okay, where we could have Mobus type 2 that progresses to this complete heart block. Okay, so it's conduction failure, we said, above or below the AV node. We mentioned a number of causes, but remember, they tend to be the same causes as Mobus type 1 or 2. Okay, they're just a progression of those. Now, clinically speaking, these patients are at high risk of hemodynamic compromise, okay? Ventricular standstill, VTAC, and sudden cardiac death, and they really need monitoring and a permanent pacemaker placed. In terms of the regularity of the rhythm, it's a regular rhythm, but remember, these are independent atrial and ventricular intervals, okay? So the ventricular rhythm, the QRS complex, the R to R intervals will be constant throughout, and so will the P to P intervals, okay? But they'll all be at their own independent rate, okay? And that's where we get to next. The rate is independent. And remember, the P wave or atrial rate is greater than the ventricular rate, okay? And the QRS rate really depends on the escape rhythm. If the block was higher in the AV node, above the AV node, then we could have this junctional escape rhythm where we'd have a rate between 40 and 60 beats per minute. If it was lower, as in the second region, okay, meaning down here in this second region, we can have a ventricular escape rhythm where the rate would be less than 40 beats per minute. In terms of the P waves, they'll be the same morphology, right? They tend to, there's no really issue with where the P waves or the impulse is originating from. It just cannot get through to the ventricles, okay? So P waves will be same morphology and access. In terms of the P to QRS ratio, this will vary, right? Okay, obviously depending on what the rate is going on throughout this, right? Whatever the atrial and ventricular rate, we can see a varying in that area. In terms of PR interval, it really varies, right? We said maybe this looks like a PR interval, but in fact, they are not related, okay? So there's really no pattern and no PR interval, or no true PR interval, because there's no AV nodal conduction, okay? Now the QRS interval will be normal or prolonged. We said it's normal if it's above the AV node, in which we can have a junctional escape rhythm, and then it could be prolonged greater than 110 milliseconds if it's below our AV node, where we have a ventricular escape rhythm with these wide QRS complexes and a rate less than 40 beats per minute. There's no grouping and there is no dropped beats in this case, okay? So like first degree AV block, there are no dropped beats, all right? In second degree, we did see dropped beats. However, in third degree, we do not see them, okay? So again, just go back through all these AV blocks and make sure you can differentiate between all of them. Well, that's the end of this lecture. We discussed third degree or complete AV block, including its mechanism, EKG features, potential causes, and clinical significance. I hope you learned something.